Good morning, everyone. First of all, very warm thanks to Dr. Vijayakumar and the entire organizing committee of 3D Diabetes Discussion Dialogues for inviting me today for this session. Thank you, Dr. Moses and Dr. Ramanan, for introducing. And the topic that has been given to me is a topic which I believe that many of you have already heard, but I believe that I will try to give my own insights to this topic and bring some new flavor to your understanding as far as diabetes goes. The topic is hit hard, hit early, a proactive way to manage diabetes. I believe that all of us know that we have to start the treatment of diabetes for our patients in a very aggressive manner, and that's the way that we have been taught always. Since 2008, when the legacy effect and its every facet started to come out in the arena of medical science, we all started to do things in the way that science would have actually commanded us to do. So the idea here is that what exactly are we hitting at? When we talk about hitting at diabetes, what exactly a general person, a general doctor, a primary care physician, or any doctor at a senior level also, what exactly are they doing with diabetes? Primarily what they have been taught is that we have to hit down sugar. If we keep on hitting down sugar, we keep on achieving what we want to achieve in diabetes. But as we talk, the world has been changing dramatically, from biochemistry to molecular biology to genetic science, from population to ethnicity, and now we are talking about individual medicines for individual patients which are based on genomic sciences. From glucocentric to organ protection, and now we are talking about adding more life to years when patients are diabetics. From spot blood glucose sugar to HbA1c, now to glycemic variability and time in range. From drugs to therapies, now to precision medicine, for pharmacokinetics to pharmacogenomics, and from biomarkers to genetic makeup. This is a very interesting cartoon. I have never been able to ever overcome this cartoon. This is the story of, we all know the story of four blind men. And four blind men, they approached the elephant, and one touched the trunk, the other touched the tail, one touched the ears, and everybody had an interesting perspective to it. So one said that it's the muscle that is causing the diabetes. The other said it's the beta cell. The other one said it's the liver, it's the genes, it's the fat cell, it's the insulin receptor. And everybody had their own perspective on it. And we call them blind primarily because the real truth is that nobody ever has been able to come till now to know that what is the exact process by which diabetes is happening in the human body. If we talk about the therapeutic advantages in type 2 diabetes, in just last 5 years or so, more than 40 new treatments of diabetes have come out in the market. If you look at last 10 years, you would find that the progress which has been done in the last 10 years is actually equivalent to the progress that was done before in 50 years. So all these medicines, GLP-1 receptor RAs, SGLT2 inhibitors, DPP-4 inhibitors, their congeners, their way, how they function, and also the methodologies by which they are even functioning in non-diabetic patients. It's so exciting that we have actually changed the paradigm in which we were looking at diabetes in a very new wavelength. Despite the availability of numerous medicines, diabetes remains the 9th major cause of death globally. More than 50% still develop microvascular complications, 25% or more they develop macrovascular complication, and 1 in 4 people in diabetes, they develop CKD. So diabetes remains the challenge. Now, treating early with agents like GLP-1 receptor RNA, they have got benefits of multiple organ protections, and the legacy effect of the metabolic memory is maintained regardless of the later glycemic status. So like I said, whether it was the UK PDA study or the DCCT study, they all told us one thing, that if you are going to treat your patient suboptimally and not try to bring down the HbA1c, even for a loss of not bringing down HbA1c by a single %, which you could have actually managed, you are going to miss the chance to bring down myocardial infarctions and all-cause mortality by a high percentage. So you are actually increasing the risk for the patient throughout his life. So imagine that for the first 10 years, if the patient was not treated properly, not treated aggressively, was treated suboptimally, the type of risk that the patient is going to entail is going to remain for the life of the patient. It's not just going to be for those 10 years, but the entire life of the patient is going to get impacted. Despite modern evidence-based therapies, residual cardiovascular risk has still remained. So even if we are taking care of the best targets in the cholesterol of the patient, the blood pressure of the patient, the glycemia of the patient, there is a residual obesity risk, there is a residual inflammatory risk, there is a residual diabetes risk, or a lipid risk, or a thrombotic risk that is going to persist for the patient. And the funnel you can see on the left side, it is always going to filter out something which is going to create the complication. Now, if this was the only perspective, that we have to treat the patient hard and we have to hit the diabetes hard and hit early, then I believe that I would have stopped my presentation of my slides here, because this is what sums it, this is what kills it, this is where we end. But the story is only half told, and I believe that Dr. Vijayakumar has called me here because I want to give the whole perspective, the whole story to you as of today. So the story changes from here on, because we all know that diabetes is the leading cause of so many diseases, including kidney failure. Look at this picture, see that if the patient is having cystic disease or glomerulonephritis or hypertension, the risk is not as high as much as the patient is going to have the risk if he's going to have diabetes. Look at that black string at the top of everything, which is showing that more than 40% of the people with diabetes will finally develop CKD, and some of them require transplantation or dialysis. Now this other slide is even more interesting. This was done by a Korean guy by the name of Wen. And what did he say? He said that if somebody is having an early CKD, look at this. If somebody has an early CKD, his lifespan is reduced just by 6 years, only by 6 years. Somebody has diabetes, lifespan is decreased only by 10 years. But if somebody has diabetic kidney disease, that same lifespan, it gets reduced by 16 years. So even for a native kidney disease, the patient's lifespan is not getting as much affected as much it is getting effective if the patient is having diabetic kidney disease. And this is for both men and women, and the numbers do add up. What is pharmacogenomics? Now, this is a very interesting science that is coming up. Earlier, we had the same diagnosis, the same prescription. You come to me, you are a patient of diabetes, I look at you with the same vision, with the same prism, and there are going to be, the ideal situation would be the drugs which are not toxic, but the ones which are beneficial. Then there are drugs that are toxic, but they are not beneficial. Of course, they go out of the picture. We don't want such drugs, which are only toxic and not beneficial also. Then there are drugs not toxic and not beneficial. These are drugs which we all know that there are so many multivitamins which are prescribing. We don't know whether they are toxic, whether they are beneficial, but we keep on prescribing it. And drugs which are toxic but beneficial. Now, these drugs are the ones which will only affect some of the people. It's not going to be toxic for some people, only beneficial. And this is how the drug development is taking a new shape. We are not talking about ethnicities here, we are not talking communities here, we are not talking populations here. We are talking about a simple, single individual, and that is where the individualization of drug treatment is going to be the name of the game, because now we are going to have genetic analysis of each and every patient. And GIVA studies which are being done, that is genome-wide association studies, they are already underway, and they are going to give a genetic imprint for each and every individual that is going to come into your clinic, and they are going to have a genetic imprint, and there we are going to have the exact list of medicines. On what is going to enable this? Everything is going to be enabled by artificial intelligence. So looking ahead from 10 years from now, we see that type 1 diabetes and type 2 diabetes will redefine itself with endotype subtypes. There are going to be patients who are going to have genome sequence in their medical record. It's going to be polygenic risk scores with ancestry specific, endotype relevant, and a new generation of therapeutics is going to emerge with many new insights about the pathways which are going to be derived from genomics. But that is 10 years ahead of us. Right now, what are we doing? We are having the same considerations. We are having the consideration of glucose control, blood pressure control, lipid control, and one very important consideration with Western medical fraternity will not acknowledge, but it is acknowledged very much in our country, is infection control, especially UTI. Many of our patients, they get admitted in the hospitals. Many of our diabetic patients, they die because of infections. Somebody is having a community acquired pneumonia which is not getting treated because he's having a sugar which was not under control, tuberculosis not under control because of diabetes, so many infections. Western populations, they don't have such problems, but Indian populations, subcontinental populations, they do have such problems, and that's why infection becomes a very important understanding in our paradigm. But still, even today, most of our fraternity is still glucocentric. They just want to talk about one thing, and that is glucose control. Let's talk about more and more glucose control. You bring down the glucose, this happens. You bring down glucose, that happens. Everything is explained by getting the sugars under control. But what is happening next is actually very different. Now we are having drugs, and this is a very important statement that I'm making. Two very important things have happened in the recent decade. We have drugs meant for diabetes which are not being given only to diabetics, and you know where I'm planning to go ahead with. There are SGLT2 inhibitors which are being given to diabetics and non-diabetics. And also in the recent market have been introduced medicines that do not control the blood sugar, and yet they are being given to diabetics. And we are talking about non-steroidal mineralocorticoid receptor analogs. They are not controlling blood sugar. They don't control blood sugar, and still they are meant for people with diabetes. This is something which is phenomenal. Drugs which were introduced in the market for diabetics, but not just given to diabetics, but also being given to non-diabetics, and drugs which are given to diabetics, but they are not meant for only for control of glucose. They are meant for something else. And that's why the new terminology that has come in is dual action. We want not just glucose control from the medicines. What we want is dual action of glucose control plus organ protection. If we do not offer organ protection to our patients, then we are just hitting hard, we are hitting early, but we are not hitting with the right weapon. That is very important. That is where the complete story comes. This is the paradigm shift in the approach. Earlier it was glycemic management, blood pressure and lipid control. What happened next? What was the fourth pillar that was introduced? The fourth pillar that was introduced was to give our patients agents which have got proven cardiovascular and kidney benefit. If this fourth pillar is not taken care of, is not paid attention by us in the present decade, then all the development, all the innovation that has happened in the past decade will just go to the dust. So we have to understand that this is a very important pillar in our understanding, that unless and until we are not giving our patients agents which have proven cardiovascular and kidney benefit, we are not going to help our patients with anything. Now this is evolution in science. To many people, what is creative disruption? We started with Edison's bulb. What was Edison's bulb giving us? It was giving us light. Then we came up with CFLs, that is tube lights. And tube lights were also giving us creative disruption because they stopped the use of Edison's bulb altogether. And finally, you see around yourself, your rooms are now lighted only with LEDs. Now, if somebody would come to me and ask that why are you giving this example in a forum which is meant for medical science, it is primarily been given because Thomas Edison's bulb, the CFL and the LED, they all provided light. They all provided luminescence. And same happens with other medicines also. Every medicine that is present in the arena of diabetes, it is bringing down sugar, just like Thomas Edison's bulb was also giving us light. Then why was it replaced by the LED? It was replaced by the LED because of certain advantages. And those advantages are what are creative disruption. So our job here today is not just to bring down the sugars of the patient. Our job is to give them a longer life, because now we have moved on even from organ protection to longevity. And most of the studies that you would find that are being present in the arena of diabetes, they talk about the number of years that are getting added to the patient's life. Another very important review article that came up was for the evolution of pillars of therapy to reduce heart failure risk and slow the diabetes disease progression, and this was by Dr. Bakris. And he clearly said that 3 pillars of therapy have slowed kidney disease progression by more than 50% to RAS blockers alone. And these finerenone and SGLT2 inhibitors, they are the ones that are the leading lights in this way. And these become the 3 pillars RAS blockers, SGLT2 inhibitors, and non-steroidal MRAs becoming three very important pillars that are maximally slowing down the diabetes kidney disease progression. Diabetes kidney disease is not going to happen in 10 days, 20 days. It's going to happen over years. And it's going to take number of years for the patient to realize, or the even doctors to realize, that whether there is a benefit there or not. So if somebody comes to me and asks you that, doctor, have you seen any benefit? Then my answer would be, I have to see it for 20 years before I can tell you that I have seen benefits, because I have to give it continuously to the patient, and one day I will tell you that the patient did not land up in the dialysis unit or a transplantation unit or the cath lab. This is also very an important thing, that you can see that the drugs that are getting introduced, they are being used for non-diabetic patients as well. A statement that I already made. This was not seen before the past decade. It didn't happen. The drugs that were introduced for diabetics were only meant for diabetics. They were never used for patients who were non-diabetics. But now that change is slowly and steadily happening. People are talking about weight management, weight regulation. I don't think so. It's a separate issue from management of diabetes. And because weight management is such a big cosmetic issue for many populations in this world, it becomes a very interesting proposition commercially. But my take would be that we should not discuss weight out of proportion of diabetes. We should discuss it together, and both these problems can be solved together as well. This is what personalized decision medicines, precision medicine is going to look like. Pay attention to this. Dexamethasone with GLP-1 receptor analogs. How it is going to happen? Why are you giving dexamethasone to the patient? Because there are certain subtypes of diabetes that are going to happen immediately because of autoimmune dysfunction. And in such kind of patients, dexamethasone is going to do a wonderful job, and we cannot deny that patient such an opportunity, because we have seen that some patients develop diabetes in a matter of 1 year or 2 years. Some autoimmune process is happening because of which their islets of Langerhans, the beta cells of islets of Langerhans, they're getting apoptosis immediately. And if at that point of time we know that there is going to be a genetic predisposition and dexamethasone is offered to these patients at the correct period of time, we may save them from actually developing diabetes later in their life. So before we conclude, we have to understand that future, as for the future, our task is not to foresee it, but to enable it. All of us, we are proponents of science. Whatever science tells us today, we have to embrace it. We have to go forward with it. We don't have to challenge it. We are not people who are going to foresee the future. We are the people who are going to enable that future for the many generations to come forward. This is the image that I want to leave with you forever. This is a doctor who's trying to save a patient's heart, kidney, and brain, and other organs also, by giving water to the patient at the very early stage. This is a doctor who's trying to do the same thing, but he's got a burnt out disease. So many a times I come across people who say that, okay, I started this medicine, the patient came to me and I started SGLT2 inhibitor, the patient's creatinine was 4 and he did really well. I'm not that happy with that. There are doctors who also come said, okay, there was this patient who was nearing dialysis and I tried to start him on SGLT2 inhibitors and finerenone, and he also did very well. Believe me, you cannot help a patient at this stage when the house is already burnt out. These drugs which we are talking about, which are adding years to the life of the patient, which are actually giving patients organ protection, they have to be started very early on, when the house is just getting the spark of fire. It's just starting to burn. When the house is already burnt out, medicines like SGLT2 inhibitors or finerenone, they are not going to have an impact on the patient. And this is my last slide, and thank you so much for your patient listening. I hope that I was able to change the perspectives.